Hello, everyone. Welcome to Lifestyle Matters. My name is Dr. Fergal Armstrong, and once again, we're chatting with Charmmy Cheng of the Dietitian's Kitchen. And this episode is brought to you in association with Careversity Health. So, Charmmy, I thought we'd talk today about the management of irritable bowel syndrome. How would
That's
you think about the approach to IBS management?
yeah. So in last episode, we talked about IBS, and then we know that IBS is actually no cure, but we can manage the symptoms. So
Hmm.
all the treatment, all the therapy is trying to manage the IBS symptom, the bowel symptoms. And there is a
Hmm.
lot of different therapies you can choose. And FODMAP, low FODMAP diet, we're gonna dig in today. It's one of the therapies option. Yeah.
Hmm. But it's not the only therapeutic option, is it? There's other things we can do as
No.
well. So,
Yeah.
from a dietetic point of view,
Yeah.
what other things can we think about?
Well, for managing IBS, for the therapy, we can put it into two big groups. One is a diet or food related therapy, and the other side is non food related. So
Hmm.
let me just talk about the food related one. If the FODMAP doesn't work, following a low FODMAP diet doesn't work, and then we might think about other food. Maybe it's a food chemical, so we might try like a low food chemical therapy, or we need to cut down caffeine, alcohol,
Hmm.
or it's
Hmm.
fatty food or spicy food, these things. Or
Hmm.
even just
Yeah.
adjust the eating pattern.
So it's really all about trying to find a trigger and remove that trigger, isn't it?
Definitely,
When you're thinking
yes.
about diet therapy. And then, of course, we do have medication that we can use to treat the symptoms, as you say, of IBS. And I think the first line of therapy involves the use of antispasmodic agents, so drugs which reduce the risk of the bowel contracting on itself and going into spasm. And so things like buscopan, peppermint, or even mebeverine, these are all treatments for bowel spasm. And then there's the other group of drugs that we can use that basically are managing the kind of the gut central sensitization pain. So the gut pain, and they include tricyclic antidepressants as a kind of a first line agent to treat this. Now, even though we call them tricyclic antidepressants, they're actually very good for the management of sensitization pain, and such as occurs in irritable bowel syndrome. But the mainstay, or rather the thing that comes to mind for most people when they think of the management of IBS, is low FODMAPs. So, what does FODMAPs stand for?
Okay. So FODMAP stands for fermentable um, oligosaccharide, disaccharide, monosaccharide, and polyols.
Right. And when we're thinking about fiber classification, how do we actually classify fiber in totality?
Well, it really depends on how we want to look at it. For fiber, we can look at it into their solubility. Then we will
Mm,
talk about if they are soluble, they are insoluble, or they're intermediate soluble. Well, if we
mm,
look into the fermentability, then we can classify them into highly fermentable or slowly
mm,
fermentable or even
mm.
non-fermentable. But then we
Yeah.
can also look into their sugar chain, like it's like a monosaccharide, then it means it only got one sugar, or disaccharide, it got two sugars connected together.
Mm. And an oligosaccharide has how many sugars?
Well, that's like three to six sugars linked together.
Yeah, yeah. So really, is it fair to say then that the FODMAPs are fermentable soluble fibers
Mm,
mostly?
yeah, mostly fermentable, and depends
Yeah,
how quickly they ferment in the gut.
yeah. And of course, when we're thinking about fermentation in the gut, it's the action of bacteria on these sugar sub molecules that causes gas. And of course, when we have gas in the colon, that's when we get bloating, distension, pain, wind, and of course, also these fermentable products attract water from the bloodstream back into the bowel, and that then can cause diarrhea. So that's how these molecules cause the symptoms of irritable bowel syndrome.
Hmm.
So let's look into specifically what these molecules are. So we've got oligosaccharides, disaccharides, monosaccharides, and polyols. All right.
Yeah.
So what are the oligosaccharides that we're worried about for IBS?
Right. So the oligosaccharides, as I mentioned, is like 3 to 6 sugars connected together, and they are relatively long sugar chain. And usually we can find them in our bean products, beans, legumes, these products, they have the oligosaccharide. And then another example for the disaccharides, that means the two sugar chains connect together. And an example will be the lactose, our milk sugar. That's the galactose and the glucose connect together to form the lactose. So that's our milk sugar. And monosaccharide is just one single sugar. So the examples will be the maltose and also the fructose and also glucose.
So actually, going back to the oligosaccharides, you've spoken about what kind of food products contain oligosaccharides, but specifically, what molecules are we talking about when we refer to oligosaccharides?
Mm, that molecule we will talk about is like GOS. It is galactose oligosaccharide. That's the galactose and oligosaccharide combined together. Or is the FOS, the fructose oligosaccharides.
Right. So galactose and fructose, when they're joined up in little chains of 3 to 6 units, that's a GOS
Mm.
for galacto-oligosaccharides and an FOS, fructo-oligosaccharide. And polyols, what molecules would occur in the polyol class?
Mm-mm. The simple examples we can see will be those sorbitols or xylitol or mannitols, and we use as a
Mhm.
sugar sweetener in our food products, and we call that sugar
Right,
alcohol.
right. Sugar alcohols. All right. So we now know what FODMAPs means. We now know the specific molecules that are FODMAPs, and we know how they relate to the overall classification of fiber. Now, let's then move to the specific foods. So, you mentioned already that uh, FOS and GOS is found in legumes and beans,
Mm.
right? Are there any other products that contain a lot of FOS and GOS?
Yes, actually, not just in the legumes. For example,
Mm,
for the FOS, we can find them a lot in our grain products, like the
hmm
wheat, the rye, also some vegetables like onion, garlic, artichoke. These vegetables, they are quite high in FOS.
And what about
Mm.
the oligo? So we talked about oligo. What about the disaccharides? What food products contain a lot of disaccharides?
Disaccharide will be mainly talking about our dairy products like your milk
hmm
or your
hmm
certain types of cheese or some yogurt.
hmm
Mm.
hmm And then the monosaccharides,
For monosaccharide, that would be maltose. So that
right?
maltose is basically just a sugar, a type of sugar. Yeah.
Mm. And is there a specific food product associated with that?
Well, in my understanding, I saw maltose in a jar, and it's like a jar of sugar, and it's purely
All
maltose.
right.
Yeah.
Okay. All right. And then the polyols, sorbitol and mannitol, where would you get those in your
Yeah,
diet?
these sugar alcohol is quite commonly used as a sugar-free products. For example, your maybe your diet coke, and also like a
hmm
sugar-free candies or like
Mm.
sugar-free cakes. Yeah,
All
these.
right. Okay. So we've got the theory about the low FODMAPs diet. How does it work in practice? So someone comes to you and you've decided, yes, this patient has got irritable bowel syndrome. Yes, this patient would be appropriate for the FODMAPs diet. So how would you make that assessment that someone would be appropriate for low FODMAPs, first of all?
Mm. So, if a patient comes to the clinic to see a dietitian and they have diagnosis with IBS,
Mm,
then we're gonna start talking about FODMAP. First things, of course, I'm gonna take a diet history to find out what this patient usually eat, and then
yeah.
ask questions about do you know what types of food is your trigger, and then they can give me a long list about the food they think they are triggers for
Hmm.
them. Once they give me the list of the food they think they are trigger, it's quite common they are avoiding them already because they think when they eat this food, they feel very uncomfortable, like they might have wind or gas or bloating. So usually when they come to see a dietitian, they have stopped eating this food already because they make them feel pain and uncomfortable. But the FODMAP idea, this low FODMAP diet, how we're gonna apply to this patient is very important. We have three stage. The first stage, we gather all the information, and then we have to make sure that these patients can follow a very restrictive diet first. So we need to ask question around, can you make sure that you eat a quite restrictive diet? Who's cooking at home? Who's doing the food shopping? Making sure they don't eat out very often. And if they said that's fine, they can do that. All right. And then they have to follow a very low FODMAP diet for maybe like 4 to 6 weeks.
So that's a very restrictive intervention, isn't it? So can we
Yeah.
just clarify what foods are we avoiding in this low FODMAP phase, this initial 4 to 6 weeks? What are
Mm-mm.
we actually saying no to?
Yeah, that can be quite a lot of food here, but
Mm.
it would be a lot of grains and vegetables, and also different types of artificial sweetener they have to avoid. For the food group, I would say in our vegetable groups that we will need to avoid like a lot of vegetable, including onion, garlic, some types of the fruits. Maybe they are avocado, passion fruit, strawberry, different types of things. There's a long list we need to go through that with the patient. And also for the grain, mainly we're gonna ask them to avoid these wheat products or rye and oat. So therefore, usually we'll ask them to stick with a gluten-free diet. That's probably easier for them to avoid these food.
So that's why people with IBS sometimes think that they've got celiac disease because they feel better on a gluten-free diet because it's taken away the
Yeah,
wheat
yeah, they
products,
feel
which
better.
also are FODMAPs.
That's right. That's why the
So
screening for
yeah,
celiac is really important. Yeah,
yeah,
sometimes
yeah,
maybe they have celiac, but they thought they are IBS.
yeah. All right,
So
okay.
yeah, definitely gluten has to be out. And also in a dairy session, then we usually recommend the patient to have like lactose-free products. Yeah, avoid certain types of cheese and yogurt at that moment, at that stage. Um, all right, that's the first part. So they have to follow this restrictive diet, plus they can't have so much marinated food or processed meat as well. Once they follow that, the symptoms seems really good, no symptoms, well controlled, which means there's something that high FODMAP trigger the symptoms. All right. If people still have symptoms, then we probably have to think about other therapy because likely it's not the FODMAP trigger the symptoms.
So if you get better in this exclusion diet, then it proves IBS and it proves a FODMAP as the culprit. I suppose the question then is which of the many, many, many FODMAPs is actually the culprit for that individual patient?
Yeah, that's right. We just proved that it should be the high FODMAP food trigger them. If they have a low FODMAP diet, they are good. But the very important part is that comes to the second stage is they have to have a
Mhm.
reintroduction of these high
Mm.
FODMAP food in back to their diet. I noticed some patient that they just help themselves. They Google it and notice these food are high in FODMAP, and they just cut them off from their diet for the rest of their life. All right, and I'm just
Yeah.
not going to have these food forever, and that's not good because that can increase the risk of like a certain nutrients deficiency or malnutrition, We don't want that. We
Mm.
try to help them to understand how much they can tolerance. That's why the second part is really important. You need a dietitian to guide you to do that. And then we're gonna have a list and we start from the challenge.
So how do you start this challenge diet, this second phase?
Right. So
Like what
one
what what do you choose to go first?
That's a really good question. So that would be a discussion with the patient because usually they will let me know that, well, I love certain food, but I cut them off from my diet for a long time because I think they are the trigger and I really want to bring back them to my menu. And then we might
Mm.
start from those food. And each time we will only test one food at a time. And in the background, they
Mm.
have to stay in a low FODMAP diet.
Right, right. So how do you introduce one food at a time?
One high FODMAP food at a time.
How do you do that? Like, I mean, do you just like if it's mushrooms, for instance, do you just have one mushroom? Do you have 10 mushrooms? Do you have a plate full of mushrooms?
Well,
How do you go about doing this?
right. So that the amount, usually it's based on how much they used to have, and they have to only had one third of their usual amount.
Ah, right,
Mm.
right. Okay. And what symptoms are you looking for then to make that the diagnosis of that particular food being the culprit?
Yeah. So once we get into the stage two, that we're gonna start reintroduce these high FODMAP products, food products, we're gonna start a little bit like, for example, like you said, mushroom. One third of the
Mm.
mushroom maybe is a handful for them, and then they have that every day, continuously
Yeah.
for 2 to 3 days. If they have no symptoms, which means they
Mm.
can tolerance one third, and then
Yeah.
after 3 days, they all good. We might want to increase the amount to 1.5 handful or maybe 2 handfuls to test. Or if this patient said, I had 2 handfuls of mushroom today, but I start feeling like uncomfortable bloating or any other
Mm.
symptoms show up, then that means
Yeah.
we have to stop at this stage. Then this patient has to stop having mushroom, not even one
Right.
till the symptoms settled. Then we will
Right.
have to answer that this patient can only tolerate one handful of mushroom a day.
And so how long does this process go for then?
This process depends on how many food items we need to test. Usually, one food items we takes like 3 to 6 days, 3 to 1 week, because like if they have no symptoms trigger, okay, we're happy with this amount, we might move on to a next food items. But if the patients want to keep testing to know their maximum tolerance amount, then they might start experiencing symptoms. Then they have to stop and wait until they settle with the symptoms and then we can continue. So it might take a long time.
So that's the second phase. What's the third phase?
Well, the third phase is called a personalized diet, which means
Mm.
now you should know for this high FODMAP food how much you can tolerate. You should have a list
Right.
now, and then now you can introduce this food back to your diet. But now you know how
Mm.
much you can have each time. So you can have normal diet, but also include this high FODMAP food, but you will know how much you can have.
Right. Right.
Mm.
Okay. So really, it's quite a long, drawn out process that really does require the input of a dietitian. It's not something that a patient can do on his or her own, is it?
Yeah, dietitian support will be important, but also family support is very important. And because it's
Mm.
gonna be a very long journey for them to do all the testing, and they can probably
Mm.
only come back to see a dietitian once a month. So it's very
Mm.
important they have to have a little um, diary to record all the food they're testing, the amount. They have to record how much they eat, what
Mm.
symptoms they experience, and get back the diary to the dietitian to discuss, oh, this is what I experienced, like that.
Yeah. Yeah.
Mm.
All right. Well, look, Charmy, thanks very much for talking us through what is really a very complicated process, but it's one of the foundations of the management of irritable bowel syndrome. So I really appreciate your expertise today. Thank you very much.
You're welcome.
That's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Lifestyle Matters.